we are really excited to be in community with you all to have a conversation about Black maternal health and reproductive justice. I welcome all of you who have been to one of these before. Welcome back. If you are new to this space, I'm going to tell you a little bit about our social medicine rounds. As I mentioned, if you haven't yet checked and double checked your voting status, please do so now. Can I emphasize enough how important that is for things like making sure that we're keeping our communities safe? So I'm going to go ahead and get started. I'm Stella Sappho. I'm an HIV primary care provider, and I am one of the social medicine curriculum leads at Montefiore. I am a primary care social medicine alumni, and I have the pleasure today of being your moderator as we have this discussion. I want to tell you a little bit about our social medicine rounds. And so for many of you who are in academia, you may know rounds as a time where academics get together and talk about highfalutin topics and, opine about the latest research. Social medicine rounds are meant to be a little bit different in that we specifically have created it so that our community members can join us. And they're created by a group of individuals who range from trainees to community members and faculty that are coming together to present topics that we think are important for our community. And so among the topics that we presented in the past are about substance use disorder, activism within the Bronx with the Young Lords work, as well as community engagement around COVID-19 protection. We've had a series of talks that have really focused on understanding how our community is really responding to certain realities and certain challenges. And we're very, very pleased today to be able to do the same. And so I'm going to go ahead and actually turn it over to Dr. Erin Goss to introduce our speakers, and then I'll center us and we'll go ahead and hear directly from our speakers. Dr. Goss?
Thank you, Stella. So I wanted to introduce our two speakers. First, I'd like to introduce Ekua Ansah Samuels. Ekua is currently the Residency Education Program Manager here at the Department of Family and Social Medicine. Prior to this, she worked with a range of private providers and nonprofit organizations serving pregnant and parenting women, youth, and families for over 16 years. She's attended dozens of births, supported postpartum families, while building a city-based community doula program and coordinating health education programs. Ekua is also a lactation counselor, providing education and guidance around infant feeding and helping to address issues with breastfeeding when they arise. She loves that her public health career is rooted in addressing social and structural determinants of health for adolescents, women, and families of color. She is a wife and a mother of 3, ages 21, 19, and soon to be 17. She believes that everyone in society, from bus drivers, grocery clerks, professors, and lawyers, if they were doulas, the world would certainly change for the better. I'd also like to present our guest speaker, Ms. Shawnee Benton Gibson. Ms. Benton Gibson is the co-founder and CEO of Spirit of a Woman Leadership Development Institute, which was established in 2002 to educate, elevate, and affect positive and sustainable transformation in the lives of individuals, groups, families, communities, and institutions. Under Shawnee's leadership and vision, Spirit of a Woman offers innovative coaching, counseling, and training experiences to those who are seeking to expand their power, purpose, and impact in the world. Ms. Benton Gibson is a licensed practitioner with over 31 years of professional experience. She is the co-founder of the ARIA Foundation, which is the Advancement of Reproductive Innovation Through Artistry and Healing, which was created in memory of her eldest daughter, Shawnee Gibson, who passed away on October 6, 2019, due to complications associated with giving birth. Shawnee's expertise ranges from substance abuse prevention, treatment and recovery, child welfare, youth development, individual and family group counseling, trauma, grief, loss, and bereavement, women's health and leadership, birth equity, racial equity, and social and restorative justice. Shawnee employs a holistic, cultural, and spiritual approach to her work and applies a racial equity, social justice lens at the foundation for all of the programs and services that her company provides. Her principal teaching, training, and healing tools consist of spiritual counseling, vision coaching, psychodrama, sociometry, sacred rituals, energy work, the performing arts, and storytelling as mediums to ignite transformation and initiate catharsis. According to Shawnee, doing healing work is a labor of love and liberation.
Thank you so much, Erin. So I want us to take a moment. I want to take a moment to offer space and silence for those among us for whom this topic of Black maternal health brings hard memories, trauma, and grief. I want to invite you all to take a moment and take a centering breath, to pause and tap into what brings you into this conversation, who you may be holding close to your heart, including yourself, and what you'll need to comfort, help, and heal yourself and loved ones who have suffered the trauma of racialized childbirth. Take a moment to feel where you are now and to know that we are all in this supporting and caring space together. Let's begin. So in 2022, I had the pleasure of becoming a new mom to a little girl. I, like so many other Black women, was terrified about how I'd make it through as a pregnant person and as a Black woman going through childbirth in this country, where we are 3 times more likely to die than our white counterparts during the birthing experience. I asked my partner and I asked my mom to have my back and to speak up loudly if I couldn't. I worked with an all-Black OB team because the statistics around racial concordance and morbidity were better when, as a Black woman, I had a Black birthing team. I did everything that I could, and still I was scared out of my mind, even as a doctor. I was incredibly lucky to make it through the birthing process, 32 hours of labor followed by an urgent C-section, but I and baby are healthy, and I consider myself one of the lucky ones. That is not the case for many birthing people, and especially for Black birthing people. The story of Aftershock, which I know many of you have watched, tells the incredible journey of 2 families that have to make a way forward when their loved ones are killed by a racist medical system that failed their basic needs. Shawnee Gibson and Amber Isaac Rose died from complications from childbirth, and their loved ones took on the charge to ensure that their deaths were a clarion cry for improving the journey for Black birthing moms. Their stories need to be heard, and this topic needs to be continually explored by our Montefiore and Bronx community. We are lucky today to have 2 incredible speakers, Ms. Shawnee Benton Gibson, who is Shamane's mom, who will join us and talk about her journey as an advocate and activist in empowering women and Black birthing people in particular. We're also extremely lucky to have a member of our Montefiore community, Ekua Ansah to offer her own experience as a community child health mom advocate and public health advocate. We were supposed to be joined by Dr. Alicia Liggett. Unfortunately, Dr. Liggett's family is unwell and she was unable to join us. We may also be joined by Dr. Alexia Gaffney, who is an expert in this space and an OB herself, to offer her comments as well. We have a wealth of experience from our speakers, but also from those who are listening in, and I hope that after they offer their comments, we'll be able to have a rich discussion. So to begin, I'm going to turn it over to Ekua to go ahead and set the stage for us. Ekua?
Thank you. Thank you very much for that introduction. Thank you for everyone who came, wow, and is interested in this. And cares about this. If you know me, you know how passionate I am about this. So I'm going to share my screen now. I have just a few slides, and so here we go. All right, so the headlines are there. they're everywhere. Influencers are tweeting about Black maternal mortality. CNN is talking about it. That wasn't always the case. Those of us who've been in the trenches, you know, knew this 20 years ago, knew that we were getting here 20 years ago. I always laugh because back when infographics started to become a thing, that was kind of the indicator that, okay, someone cared, you know, they want, you know, to raise awareness, they want to educate legislators and things like that. So there are no end of infographics about what's going on with the disparities with Black women and birth in this country, and certainly in New York. So how did we get here? Just really quickly, I know this is family and social medicine, so we know all too well, you know, the history of, you know, just of enslaved people in this country. Once upon a time, Black women were bred, right? And those who took care of them in birth were protecting property and a commodity, right? And then we also know, well, many of us know, I should make the assumption, but many of us know about, you know, how pain was talked about in relation to Black people in order to minimize the brutality of what, you know, slavery was, which then perpetuated the experimentation. Medical Apartheid by Harriet Washington is an excellent book that really maps all of this out. Those of us in maternal child health and obstetrics and gynecology know about Dr. Marion Sims, who is touted as the father of gynecology, and he experimented on enslaved women without anesthesia. So, you know, you have physicians saying that Black people don't feel pain, and that definitely goes on to how we were experimented on in our reproductive justice. Researchers and advocates know about, you know, contraception and coercion and all those ways in which throughout history down to present day, women of color are targeted and experimented with and coerced, and the policies that support them. HRSA has a really good timeline on their website, Maternal Child Health, and it starts in like the 1800s. You get to hear about, you know, when the Bureau of Child Services starts and when vaccination starts and things like that, and it gets really dense in the turn of the 20th century. But, you know, when you look at the history and you look at these things, it's really easy to, you know, look at these successes, what are deemed as successes in public health. But when you look deeper, many times they have marginalized and undermined Black people. For example, the Shepard-Turner Act, it is touted for, it's the reason why state health departments have a maternal child health full-time division. It, you know, it's where the funding came from to train public health nurses in the early 1920s. But the part of the story isn't told is how, you know, public health nurses were used to target and criminalize those women who had been catching babies in our communities and caring for Black women for years. So, like, that's always a lesson for me as we're looking at history, just really paying attention to who these, you know, policies affect. And then there are hospital policies and procedures, which for those of us who, you know, are doulas, birth workers, nurses advocates, you know, we see that the tone more often than not is, this is how we do things here, not this is what this particular mother in front of me needs. So this is part of the story of how we got to where we are. As a maternal child health professional, I have seen the, the changes in the priorities of focus when it comes to maternal child health. Early, like 20 years ago, in the very beginning of my career, it was all about infant mortality. It was all about the fact that babies were dying. Our Healthy Start programs were started as a result of there being disparities in poor communities, in communities of color, where babies were dying at a disproportionate rate. There are accounts, I couldn't find any pictures, but at one point, for advocates right here in New York City, they took coffins to the steps of City Hall to get legislators to do something about this problem. So we go for infant mortality. You know, you see a focus in premature and low birth weight as an effort to focus more upstream. And then in the 2005s, you had a lot of research and awareness raising about preconception and interconception care, and the funding priorities for the federal government, the state and local governments centered around making sure women are healthy, just so that if they have a baby, that baby is not premature or low birth weight or dies. So now we're putting money into all these programs that are doing nutrition and health education, things like that, so that, you know, women, before they even think about having a baby, are healthy. And unfortunately, with these shifts in priorities, you don't get enough time for the needle to move, right? These are all issues in front of us that need attention, right? About 2010, you know, those of us in the trenches and reading the research, we knew that it wasn't just poor and low income, uneducated women who were having poor birth outcomes in the Black community. Once upon a time, all those initiatives, the public health focus, centered around women who were low income and didn't have much education. So around 2010, that's when, again, funding priorities happened. We're not just targeting that populations. We're learning that, you know, women who are highly educated, Black women who are highly educated, who are making 6 figures and more, are still at risk for premature and low birth weight. And racism starts being called out as the reason. They're no longer clusters at conferences about, you know, the problem's racism. Folks are showing us maps and data about how racism is affecting these issues that, you know, have so many, you know, efforts towards them and making no or very little headway. And so then there's a focus on, you know, targeting the culture of induction, the culture of elective C-sections with, you know, healthy babies are worth the wait. And now we find ourselves here talking about maternal mortality and morbidity, because all these initiatives just didn't last long enough or weren't invested in long enough to make a difference. So what we do know, and what, you know, most birth workers will tell you, most doulas, community health workers, breastfeeding advocates, midwives, you know, doctors, nurses, they'll tell you that the birth experience matter. Someone has to answer for everything at every level. In the film that, you know, in the Aftershock film, both of the families that were centered, one of the dads said, that his partner was dead the minute he walked into the hospital. You know, in retrospect, after he's lost his partner, he's accounting the incidents of disrespect, of being ignored, and being and issues being set aside. And so that someone has got to answer for that front office person who's rude, that, you know, doctor who maybe has some microaggressions, and then those concerns that did not get addressed. Also, in order to make, you know, help keep, you know, Black women safe, one thing that myself and other advocates do is help women and birthing persons be intentional about who their providers are. If you can't say, I have a great doctor, keep looking. Far too often we talk to folks and it's just like, oh, how's your doctor? You know, that it's like, oh, they're okay, you know, but we can't afford to do that. It's not okay to just be okay, because in those instances when everything isn't going well, they're okay, doctor. It's not going to save your life. Another thing that us birth advocates are trying to work and do more is to match providers with risks and match birth settings with risks. A lot of low risk women are in high risk facilities and seeing providers who really don't know what natural birth looks like. So just kind of bringing back the concordance between, you know, a mom who has no health issues and therefore may not necessarily even need an obstetrician for a birth, and maybe is a great candidate for midwifery care or to birth in a birthing center. So those are some of the conversations that we have with our moms. And one of the biggest things that is very unfortunate with the way things are now, which I know is certainly compromising the safety of Black women in birth, is the fact that women are seeing different providers at every visit. And that's not going to change unless women are starting to choose providers and that they can see and advocating for themselves. I tell moms all the time, see when so-and-so is going to be there if they're the person you've seen, because by the time I usually engage with them, they've already seen 6 providers. By the time they're 27 weeks, they've seen 5 or more providers, and they don't know who they're going to get. And that does not work for like creating rapport and getting to know mom in a real way and the nuances of what she needs and her care. And it's even more ideal when well care and GYN care also is the same provider for when that person is birthing. And of course, you know, awareness and whatnot. Listen to women, listen to women, listen to women. That is always, like, I can't say that enough. All these stories, we got to hear even high profile births where the story was, I had to really scream, shout in order to be heard. Developing infrastructures that are built to respond to each individual's mom's needs and not, this is how we do things. And maintaining that infrastructure, like I mentioned in the previous slide, far too often when something is trending, there are RFPs and resources and programs, but then, you know, we're always lucky when we have a program that lasts 5 years. They're usually 1 year. You're not going to see anything in 1 year. Even programs that have been around for decades, like Healthy Start, every 5 years, you have to reapply. You have to reinvent the program, you know, and there isn't enough time to do what we know works, building trust and accountability. So these priorities matter. I remember when we were advocating for baby-friendly hospitals and mother-baby-friendly, which not a lot of people know about. Mother-baby-friendly is about breastfeeding. Mother-baby-friendly is about, you know, promoting doula care and reducing interventions in birth. That was an uphill climb that didn't really happen. We didn't have too many successes with that. And during that period, we found that, I remember out of the 4 or so HAC hospitals in the city, they had like 1.5 midwives on staff, you know, like 2 midwives on staff. At one point, Jacoby had 13, and we were like, whoa. And it mattered. When we were in the room with moms, as doulas, we felt like in those spaces where midwifery care was, you know, the norm and respected, we were almost like not needed, right? Because everyone knew how to care for mom in the ways that, you know, doulas are attentive and let mom's, you know, body work as it should. Birth centers, the only freestanding birth center in New York City closed. And so now people are working to open birth center, but it's an uphill battle. I've sat at a table where midwives are trying to open birth center and the obstacles are really difficult. So any opportunity to be in that space, invest in that space, that's important. Another thing I really get very outspoken about is comprehensive health education, childbirth education, sex education. When women know their bodies, when girls know their bodies, when they know how they feel when everything is good, and they know when something isn't right, those are the ones that are kicking and screaming, saying no, calling the doctor over and over again, getting second opinions, insisting on better care if that's not what they're getting, right? Those are the ones who survive. So I'm a huge advocate for speaking to young people, boys and girls, about their bodies and what it does. Like, we're in a society where there's sex everywhere. We should not be afraid to talk to young people and tell young people to know what. I had a colleague in my sex education classes early in my career who used to tell young girls, know what you look like down there. Shine a mirror down there, know what you feel like, know what you taste like when you're healthy. And it was provocative at the time, but it's really real, because when you are firm and you know your body, you know something's wrong, a doctor can say, this is normal, it'll be okay, just rest, which is the story we keep hearing whenever we hear a story about a woman, perishing, is because she said something was wrong and a provider didn't escalate it enough. And I want to end by saying, no, there's one more, like partnerships between midwives, doulas, community health workers, hospitals. They exist. And when we're all at the table, I'm part of some of these partnerships where the doula is talking about what mom shared with us. Doulas are moms and birthing people, like, they talk to community health workers, they talk to their home visiting, their nurses, their home nurses, their doulas, about things they don't have the time, they're not given the time to bring up with their OBs, and they don't feel safe. And so when we're at the table and we're able to, talk to our clinical providers about what we're told and what moms are really going through, it really does help us to protect mom and give her the best care and the most individualized care possible. And my last remark is that birthing has always been a thin line between life and death. My mom, who is West African, has so many different ways of talking about this, and there's so many sayings. In the South, they say that when you're having a baby, it's like having one foot in the grave. From the beginning of time, we've known that this is a space that needs to be handled with care and protection. So the fact that, deaths are happening and the reasons are preventable, and many of the stories are about, concerns being taken too lightly, is really like, what are we doing here? Because we've known from ancient women knew that. And we still know that now. So I'm going to end there, and thank you for listening.
Thank you so much, Ekua. Thank you so much. I'm going to turn it right over to Shawnee.
All righty, thank you so much, Ekua, and also Stella, for creating the space for me to be here. So family, and that's how I view all of you. I see Will's face, I see Cigar's face, and hopefully I'm not saying your name inappropriately. Shawitha, not sure if that's correct. I see you nodding, thank you for the nod. I see Rebecca, I thank you for Belinda coming back on screen. So some of you have seen Aftershock, and I thank you for jumping on screen. You've seen me in my most vulnerable space and place, and through the loss of my daughter. You've experienced my tears. You've experienced me engaging in activism and advocacy and talking about the pain and the heartbreak associated with loss and the devastation that has yet to be seen for my grandchildren. So I'm asking to see you in this space as I share. No force. For me, it's always invitation, not obligation. However, there's an inequity in the space because you know more about me than I know about you. So as some of you come on line and show yourselves, I acknowledge you. If you cannot, I totally understand that. But once again, just putting it out there so that we can create more equity in spaces by being with one another. So simple, so simple. So thank you all who have come on screen. And once again, if there are some that cannot, I do understand sometimes we're not dressed properly or we're multitasking, but if you can, please do. Please do. I was so grateful to be invited to come into the space to co-create this conversation. And it is an energy of co-creation that I operate from. I don't operate from a space of I got here by myself. I don't operate from a space of I pulled myself up by my own bootstraps, because it's a lie. Every aspect of my life has been connected to interdependence. When I open up the refrigerator to eat some food, somebody made that food, someone packaged it, someone grew it, someone created the technology so it could be frozen in the ice box. What my great grandmother would say, put that in the ice box over there. And somebody has engaged in me having these lights on and using this laptop so that I can be here, and the Zoom creation, all products of interdependent dynamic and engagement. The co-creation of babies, interdependence. So when I heard that we're talking about family medicine and social medicine, I was so grateful, because that's about interdependence, this siloed way in which we do our work. I'm a social worker. I know for sure that all of those who came before me who were doing social work, whatever the names were, and the morphing and the changing, have engaged in the co-creation with community and colleagues, peers, speaking to those who were most impacted by whatever the issue was of the times. I know better than to think that I got this, that I know more than I do. I know better than to think that I can govern myself just strictly on what I know cognitively. It is not enough. Who you see before you integrates my mind, my body, my spirit, my emotional intelligence, my spiritual intelligence. What we're going to be talking about may have some pieces of study and research in it, but mostly it's me being with you as a mother, for those of you who identify as such, as a parent, for those of you who identify as such, as a leader, for those of you who identify as such, and as a community member and constituent that is deserving of respect and honor and a listening ear, or 2 or 3 or 4, right? So I just want to open this up by acknowledging my 2 parents, Jill and Kenneth. Who are your parents that co-created you? You're here. I want to acknowledge that some came by way of C-section, some came by way of vaginal birth. You're here. Some of your parents, whomever birthed you, conceived you, birthed you, pushed you out, experienced birth trauma. This is not a new conversation. And I love what my sister said earlier, that since the beginning of time, these issues have been those that we have unpacked and explored. So we get an opportunity to learn more information, not just for our heads, but for our hearts and for our minds, bodies, and spirits. It's just so important. So I want to introduce you to, oh goodness, let me see who's saying what in here. Wow, came via repeat C-section. So thank you so much, Alexia, for sharing. Kevin and Margaret, she knows this is my cousin in the space, so she knows how I get down. I would love for you to model what she just did and drop in the chat the name of your parents, and then also how you got here. My Aunt Margaret, who's Alexia's mother, and Alexia is a doctor, and she's probably going to speak in this space as well. She talks about the C-sections, and she actually talks about how glad she was she had them. And I'm like, wow, Auntie, wow. And I also know folks who've been traumatized by C-sections and also just want an opportunity. I know some now who are pregnant and they just want to have a VBAC, a vaginal birth, after C-section, just to experience pushing their babies out and not having to have the intrusive, invasive experience of C-section. So thank you for those of you who dropped the names in the chat. I want to know you. We're taught in this work not to share ourselves. Be professional. Don't break and breach that line. I'm telling you, when COVID happened, we already broke the line. You can see this is my dining room I'm talking to you through. When we go to work, nobody gets a chance to see that. I've been in meetings where the cat walked across the screen and the children are screaming in the background. Like, we've already dismantled that. So why not share your parents' names and how you got here? And thank you for being here. You made it. You made it. You made it. Thank you. Before I say another word about this crisis around reproductive health, and specifically Black maternal health and what's happening to my people, the people that look like me, I want to get related to you and know you. So thank you for just honoring me in this space by just putting in just the basic things about you. Awesome. So let me just share some things about my daughter, Shawnee Makiba Gibson. Just a few items. I wasn't going to share slides. I just wanted to be with you, but I take instruction from her, who's one of my ancestors now. Now she's like growner than me because she's on the other side. And so I'm listening and I'm going to obey. So y'all just keep dropping the names in. And whether you know whether you are a vaginal birth, I came by way of vaginal birth to a 15-year-old mother named Jill. My father's name is Kenneth. I almost forgot to say my own. I'm asking for yours. Yes, my father was 16 when I was born. All righty. So my daughter, Shawnee Makiba Gibson. She didn't like Makiba, but she can't control what I do right now in this space by sharing her middle name. She lived 11,248 days. That's a lot of days, a lot of days. She passed away 2 months shy of her 31st birthday after giving birth to my grandson, Kari, her second child. She passed on October 6, 2019, and that was 1,115 days ago. And she passed, and my cousin will be able to say this, maybe verify. I think it was a little after 11 a.m. in the morning, but I could be wrong about that. I haven't tapped back into the time, but it was definitely in the morning after a rough night fighting for her life. And us standing guard, us standing and holding vigil, us reaching out to community and our networks to ask for prayer and covering and to help her push through. And she didn't make it. So I say all of this with a shaky voice, but I also tell people, and I've been saying it more and more out loud, because a couple of people have asked me over the last almost 3 years if I could bring Shawnee back, would I do that? Well, it's actually been over 3 years now. And I said, no, I would not. What has happened since she's transitioned is nothing short of a miracle. If I roll the time back, some lives that have would have been lost would not have been saved because her story, the documentary, the social media posts, like all the stuff that we put out into the ethers about her life and her experience, her and Amber's, because, you know, if you've seen the documentary, you know, those two women, Amber 26, who passed away in your institution, Montefiore Hospital, at age 26 after she gave birth to Elias. And Elias is here breathing and living and making waves in his household and being spoiled and doing all the things that a 2-year-old should be. I would not take back her death because who I am now is unrecognizable because she transitioned. And I was already in this work before Shawnee transitioned, but it's taken the work higher and higher and it's expanded it. It's bigger than me. It's bigger than Shawnee's life. It's bigger than you as a clinician or a clinician to be or provider to be. It's bigger than your practice. It's bigger than how many patients you've seen or how many births you've witnessed or babies you've caught. It's so much bigger than that. So I wouldn't bring her back, but I'm a demand that her death not be in vain. She died one day, and that day catapulted my family and the folks that surround us, our extended networks, into a life or lives we would not have dreamed. But it's a powerful, powerful conduit for an opening, for action, for research, for new practice. And I'm so grateful, so grateful that she lived, because that's more important than the fact that she died. So Shawnee was an entrepreneur, world traveler. She was an artist, producer, director, loved children. She was a disruptor, which is a big word for a revolutionary woman for her time. Spoke up, spoke out, pushed up against things, pushed up against my parenting, pushed up against how I did things if I didn't have integrity. She was an innovator, not just as an artist, but just thinking outside of the box. Some of you can relate to that. She was a youth specialist, a seeker and researcher. And that seeker and researcher is highlighted and capitalized because she was seeking and researching about birthing and about conception and about breastfeeding and about home birth and about midwives and doulas and all the good stuff. And she still passed away. She still passed because she was a Black woman in this system that was not built for her. All of the systems in the United States were not built for BIPOC folk, and that's shorthand for Black, Indigenous people of color. They were built for mainly those who identify as white and those who identify as male. And it's hard to shift or turn the Titanic when it's already out to sea and moving. It's hard to shift or turn the Titanic, period. And so with all of that Titanic, systemic oppression, inequity, we're not going to change that overnight. But it's so important that we're awake and aware, at least some of us, and we recognize the need to ensure that people like Shawnee don't have to die doing the most natural thing, which is bringing new life into the world. I want to talk about holistic learning and the approach. It's so important when I do this work. Y'all are scholars in this space. You're powerful beings. I have no doubt that your grades reflect your brilliance. But what is problematic in this space of patriarchy, white supremacy culture, competitiveness, capitalism, is that we're taught to learn from this 1 or 2 dimensional mind frame instead of how we were designed as human beings or spiritual beings having a human experience, how we are designed to lead and learn and navigate life. So I'm going to read this to you. And as we move forward, I might use more slides, I might not. I'm just going with what the energy speaks for and to in the space right now. But I'm going to read that education with a holistic perspective is concerned with the development of every person's intellectual, emotional, social, physical, artistic, creative, and spiritual potentials. It seeks to engage participants in the teaching, learning process and encourages personal and collective responsibility. It requires that you bring your whole self, intentional capitalization, to the learning environment. So we've been taught in this system to operate separate and apart from others. The only way that we operate with folks, and I'm being hyperbolic in my speech, but for the most part, we're taught to compete with other. Your grades versus my grades. Who raises their hands first? Who's the valedictorian, the salutatorian? Who got the awards? We forget that we all have value and we all can contribute, and that our mistakes are opportunities and possibilities for us to learn and grow and transform. We pray that our mistakes won't lead to death, like what happened with Amber Isaac in this institution that you all are co-create with, and now I'm co-creating with you all too. But the bottom line is that when we don't use a holistic approach to navigate the gifts, talents, and abilities that we have, and the responsibilities that come with our leadership and the gifts that we have been endowed with, then we miss out on the opportunity to really bring our full brilliant selves to the space. Because I tell people all the time, my intellect is not enough. It is not enough. I'm going to show you an image. And I invite you to, because we're co-creating, to share what you see, and maybe Stella can share maybe the dropped comments in the chat. So this is brain lateralization, left brain, right brain, thinking about who you are as a clinician, a provider, a healer, because that's how I view folks. And I especially view those who've been called to this work as healers, because some of us are not called to the work of social work, psychotherapy, nursing, being a doctor. Some of us are in it because of the financial gain or the prestige that this society declares that these roles have. It's not a calling, or it's like, oh, I tripped into it because I was going to do this and then I just decided to go in another direction. But this work is a calling, and how we're taught to engage in the process of learning in these spaces can be impacted greatly by how we're by the framework or the paradigms that we're taught and ingrained with when we're very, very small. So you see on the left side of the brain, analytical thought, detail-oriented, perception, ordered sequencing, rational thought, verbal, cautious, planning, math, science, logic, right field vision, right side motor skills. And then you look on the left and you see intuitive thought, holistic perception, random sequencing, emotional thought, nonverbal, adventurous, impulse, creative, writing, art, imagination, left field vision, left side motor skills. I'm curious about what you see as it relates to the educational system, the hospitals that you work, or the hospital space that you work in, the spaces you navigate. What do you see as our focus? And what do you see as the side of the brain that we promote the most? Anybody? And Stella, you can start us off, or Ekua. What do you notice? Stella, any shares that are worth?
Yeah, so we're seeing a lot of folks talking about left side, that we praise the left-sided brain folks, that it's left side all day.
Got it. Thank you. And Stella, stay off mute. What's the
Yeah, sure.
implication for us being taught that that side has the most value? What's the implication for patients, for ourselves as human beings? What happens when we focus and build the muscle for the left and not the right?
Let's see, folks are kind of.
Oh, you can answer too. I invite you to share whatever your thoughts are, because we're, you know.
I mean, I think one of the things that's really interesting about this is, there's a whole realm of work that talks about where the communication breaks down for patients.
Yes.
And it's so interesting because so often we'll talk about patient health outcomes. And one of the challenges to good health outcomes is patients don't understand what we're telling them. They'll leave the hospital and have no understanding of what they were treated for, what the treatment plan is, or they'll leave their doctor's visit and know that they had a whole bunch of stuff said to them, but it doesn't actually make sense. So we talk in the coded language of the kind of left-sided brain that has a certain logic to it. And that may not be the language that our patients and our healthcare consumers necessarily need. So I think there's often a natural disconnect that happens. And yet I don't know, within medicine, at least, if we have a lot of space for right-sided brain communications. And I invite others to jump in as well.
Please do jump in. And I love that you said natural, because I say it's unnatural, right? That there's a missing. That's not natural. And I will also say that there's space always for emotional intelligence. We just have to choose to operate from that. And I don't mean the patient gets diagnosed with PCOS and you're crying at their feet. This is not what we're talking about. I'm a psychotherapist by training and a healer. I can't serve anybody well if I'm weeping and crying. And I do cry with my clients and the people that I'm charged to. My partners in healing is what I call them. But it's not so I'm taking over the whole process, but I'm a feeling, sentient, empathic being. And so I'm going to express tears. When my daughter passed, the doctors that were in the space, the nurses especially, cried because this young woman lost her life 13 days after giving birth to her child. And that's something to cry about. But while they shed tears, they were also able to support the family, to do what was required of them, all of that. There is always room for emotional thought and intelligence. There is always room for empathy. There's always room for communicating clearly and checking in with someone to make sure that they got it. There's always room for holistic perception, whether you articulate it or not. But we don't do it because the muscle that we have been taught to build is on the left side. How smart you are and using the big terms and moving things along. And then that combined with what capitalism calls for and what patriarchy demands of us, we end up doing harm when it is not our intention. So Stella, any other shares in the chat that you want to?
It looks like Rebecca has said that, we lack creativity in our evidence-based practice. It's not in a research journal, then we don't offer it in our services.
Thank you.
And if it's holistic, we label it as not evidence-based.
Okay, come on now. Thank you, Rebecca, for sharing that. Now I know for sure that my grandmother's mother, right, was a midwife. Her name was Trellis. She caught babies and she didn't do it based on research. She didn't do it based on somebody saying this is evidence-based and this has value. She did it based on what she experienced her grandmother's grandmother doing and what the community just knew and the practice in the community. I'm not poo-pooing on a study and research. It has saved lives for centuries. However, when that's the only thing that we concentrate on, then outcomes like what happened with Amber and Shawnee occur, and then we lose life senselessly. And if you've been paying attention to some research that has been done recently, between 2017 and 2019, they looked at these maternal losses, maternal mortality, and they recognized that 80% of these losses were preventable. And I haven't done research, but I'm going to tell you, if some of the right side of the brain functioning, thinking, leading would have been in the space, perhaps some of those deaths would not have occurred. Any other shares in the chat? Thank you, Rebecca.
No others.
All right, awesome. So context is decisive, family. And I call you that because when we forget that we're all interdependently living and breathing, without your patience, what you do wouldn't have relevance. So context is decisive. I have here the story. This is part of my coaching work, my healing work. I share this with anybody who will listen. What you do, what you believe, your beliefs about the patient, about yourself, about the circumstances will determine what you do and what you don't do. So whatever story you carry about what's happening will drive what you do or what you don't do. So the story happens, right? Shawnee goes to the doctor and she's telling them she can't breathe. She's struggling. She's having chest pains and just different things are going on with her body that she's not accustomed to. Shawnee, like Serena Williams, knew her body well, very physical person. She danced most of her life, went to the famous school, the performance arts school, LaGuardia High School, danced, performed, choreographed. She knew her vessel well. But they told her, you just had a baby, so you need to rest. You need to lay it on down. And that's the worst thing they could have ever told her because she had a pulmonary embolism and she died due to complications because the clots moved up her legs and into her lungs and they stopped her heart. And that could have been prevented her time she went to speak to them about what was going on, to get the staples out after the C-section, the conversations, the calling, the reaching out that I did. Her death was preventable for sure. The lens that the persons looked at her through, Black woman, young, just had a baby. So, Black girls do the most, right? So she probably needs to sit down somewhere. And that's the worst thing they could have ever told her. And then the action or the inaction that ensued was poor advice and guidance that led to her demise. Right? So context is decisive. What you think you know, what you think you don't know, that blind spot will determine what you do in the spaces that you're providing support, service, and care to the people that you're charged to serve. I'm not judging you about this. We are human meaning-making machines. But what I'm asking you to do is to interrogate your practice, to disrupt your practice, to recognize that white supremacy culture, patriarchy, and capitalism has toxified, and I don't care if it's a word or not, toxified how you show up and then determines how you process the story, the lens that you look at the story through, and then the action you take. You see these eyes on the right? If you're looking at eyes through the lens of these glasses with water in them, you will never know truly what eyes look like, and you will be scared to death to look upon them. So moving right along, there's an invisible poison that impacts our context. White supremacy culture is the idea or the ideology that white people and the ideas, thoughts, beliefs, and actions of white people are superior to people of color and their ideas, thoughts, beliefs, and actions. White supremacy culture is reproduced by all of the institutions of our society. I say this unapologetically, all of them, whether the leaders are conscious of it or not. In particular, the media, the educational system where you have gotten these degrees and I got mine. Right? Western science, which doesn't believe in some of the holistic methodology that Rebecca was speaking about earlier, right? White supremacy culture is an artificial and historically constructed culture which expresses, justifies, and binds together the United States white supremacy system. And it goes beyond the United States. It's an infection that's global, just like anti-Black racism and colorism, and all the other isms that infect our society. White supremacy culture is the glue that binds together white-controlled institutions into systems and white-controlled systems into global white supremacy systems. Right. Some of you may have belly flips, or you might be getting heat in your body, right? I'm feeling the heat. Some of this is mine because I'm presenting right now, and some of this is yours because you're projecting it towards me. I'm not here to be liked. I'm here to lead, and I can lead, grieve, and speak truth into power, even if it makes it dangerous for me, or even if it makes people reject or rebut what I say. That's what I have chosen as my lot in life, and that's my purpose, right? White supremacy culture has infected us all of us, and we all operate from it, and we all are made to operate from the context by which it drives us to lead, live, and learn. There are 12 characteristics of white supremacy culture. I wonder if you know them. And I'm going to take this down and I'm going to say a quote because I want to see your faces. I want to say a quote that I often say, and it was shared with me many years ago. If you don't understand racism, what it is and how it works, everything that you think you do understand will only serve to confuse you. That is Neely Fuller Jr. Look him up, right? Do the work, interrogate your choices as clinicians, as providers. Look at the siloed way in which we approach healthcare, reproductive healthcare in general. And when I say siloed, we're pitted against one another. Those who have specializations versus family medicine versus social medicine. In my field of study, we are taught to be pitted against one another. I have specializations too, but they don't trump the overall field. I'm grateful that I know what I know, but I don't dismiss those who have a general practice. The general practice feeds and fuels the specialization as foundation, right? And so I'm encouraging everyone to really look at what you say and what you do in your practice so that Amber and Shawnee's don't have to die. Don't have to have near-death experiences because of our arrogance and our egoic approach to the work, right? And we've been taught how to be arrogant and egoic since kindergarten. So I want to share just some of the characteristics, and I want to check in first because I know I want to make time for questions. So Stella, please share where we're at.
So I want to just give Dr. Gaffney a moment or two, and then I
have
a couple of questions before we need to break. Is it okay if we go to her next?
Absolutely. And I need to take a breath.
Dr. Gaffney, if you want to come off mute and just introduce yourself. We didn't know if you'd be for sure able to join, but if you want to just introduce yourself, we'd love to hear your comments as someone who's on the front line.
Sure, absolutely. I'm Dr. Alexia Gaffney Adams. I'm a triple board certified infectious disease physician. I trained in internal medicine and general pediatrics at Stony Brook Hospital, and then completed an infectious disease fellowship there. I went to med school at SUNY Downstate in Brooklyn. I did my OBGYN rotation at Brookdale Hospital, which is a small community hospital in Brooklyn. And every one of our OB patients was high risk. It's a very high risk community, and people had increased obstetric risk for so many reasons. And something that I did not observe in this Brooklyn community hospital that I observed in the university hospital where I trained is, just overt disparaging remarks about patients, particularly on the labor and delivery unit, or sometimes in the emergency room, the pediatrics ER. So as a med-peds resident, I had to do multiple neonatal ICU rotations. And so I spent a lot of time on labor and delivery, at vaginal births for high-risk patients, as well as at C-sections, high-risk and scheduled C-sections. And one of the things that I observed in this university hospital on Long Island is the way that attendings and resident physicians spoke about patients. And it was particularly patients of color. So in this university hospital, I learned things like when a Latina woman or Hispanic woman was laboring, her cries in pain was often mocked by the medical staff, and she would be described as being in status Hispanicus. The same would be true in the pediatric emergency room, where a woman, most often Spanish-speaking women, regardless of where they were from, when in communicating with a medical team, they would use language that they understood that a doctor would understand. So they would say, my baby has too much fever. My baby's fever is too high, is what they meant. But they would be mocked for saying too much fever. And so people would put on accents and say, oh, we got another mom in status Hispanicus, and she's, her baby has too much fever, with these mocking accents. Other things that I observed, is, and something that my family experienced with Shawnee, the assumption that Black women can tolerate pain better than other people. And so that if they were asking for pain medicine or if they were complaining of pain, that it was just drug-seeking behavior, as opposed to looking at a Black woman and recognizing that she's actually in pain. Those are just the examples that I will give in terms of what I observed. But what I also observed is that we never use language like that for white women. White women are just in pain. They are just seen for what they are, a patient who has a medical need, and they are worked up accordingly most times. Women still do experience healthcare disparities in comparison to men, who almost always are taken seriously, even if they're man-colding and man-fluing, and that's a real thing. But women of color are often not perceived as being in as much pain as they are. Their complaints are not taken seriously. And this is a medical thing. This is an institutionalized behavior. And unfortunately, it is taught behavior. So this types of behavior, this types of response to women of color, this type of not taking people seriously, as well as sort of doing the bare minimum for people, is not acceptable. I'm also a breast cancer survivor and a breast cancer advocate. And even in that regard, I received disparate healthcare. I requested to have a prophylactic mastectomy and I was told it was too radical. And then I requested genetic testing in order to advocate more for the prophylactic surgery. And I was told that I did not qualify for that. And so since my cancer diagnosis and treatment, and just understanding that Black women face disparate healthcare everywhere, including Black maternal morbidity and mortality, including breast cancer outcomes. And so when I'm sharing in the breast cancer space, and I think that it is relevant here as well, it was absolutely absurd for me to be told that removing my breast was too radical. Because if you're talking about a disease that Black women get less but die more often from, get diagnosed at later stages, younger ages, but with more aggressive tumors, then there really isn't anything that is too radical when your patient is standing before you requesting to cut off a body part that has been biopsied and surgerized multiple times. And that is true when we're talking about Black maternal morbidity and mortality, birth equity, and everything else, high blood pressure, diabetes, etc. Many of the studies that we look to make decisions for our patients were not done in people of color and not done in women. So you have gross underrepresentation of people in some of the studies and data that drive our treatment and management. But at the end of the day, we don't need study and data to just believe a person who says that they're in pain. Something is wrong. I'm concerned about my body. So if you're seeing a patient of color, hopefully you don't use this kind of language and terminology, or your colleagues and peers don't. But if they do, I encourage you to check it and to cut it off, and encourage people to see their patients as who they are. They are people who are presenting into the medical setting because they have a symptom, they have a concern, and they have an issue that needs to be addressed. And then I encourage you to just remember that there's nothing that is too radical for a patient who is more likely to die and more likely to have a negative outcome across the board, no matter what type of condition, disease state, or whatever you're managing for that patient. And I'm complete.
Thank you, Dr. Gaffney Adams. I want to go back to Shawnee to finish out on the principles of white supremacy culture. And then I want to make sure that we give folks who are on the line enough time to ask questions. Put the questions in the chat. Go ahead and raise your hand. We'll come to you as we come out of hearing these final comments. But thank you guys. I mean, this conversation is so rich. I can't wrap anything up. I want us to really be able to go fully and go deep. And so we are going to go until 6. For those who have to jump off, we've shared the link for the feedback survey if you want to share your feedback before you go. But for those who can stay, start throwing in comments into the chat. Raise your hand if you want to be able to speak and comment to the speakers, and I'll turn it back to Shawnee.
Awesome. And I won't stay on long. I'm just wanting to share a few pieces about white supremacy culture and the characteristics so that we can be conscious of it. And once again, it's built in, no judgment around it. It's an opportunity and a possibility for transforming how we navigate in spaces. So the characteristics, I'm just going to share maybe 4. And the 4 that I think are most relevant for this space. So worship of the written word is one of the characteristics, where studies, how we write memos, what we write in the charts, and those things are important, but the worship of them can do damage, so that the lived experience of folks who are brilliant, people who will do grassroots work, what Alexia was talking about in reference to how some patients express themselves or write out what they need. When we have a relationship with words that has this hierarchical feel to it, then we miss out on the opportunity to learn through other mechanisms. And there's so much opportunity and richness that BIPOC communities have to offer, no matter how they identify. And one of the others is fear of open conflict. So when you want to address racism, bias in spaces, there's a shakiness and a fragility that white folks have and BIPOC folks have as well, because we've been indoctrinated to believe that if we confront or disrupt, that we're wrong, right? And then we'll pay for it. And so we will check somebody that's Black, Indigenous, or a person of color when they confront the system or confront the leader that identifies as white or confront the leader that might be BIPOC as well, but you just aren't supposed to do that. Like, question, you're supposed to toe the line and go by what the books say, as opposed to using your intuition, being spontaneous. I was joking with my colleagues today who are co-creating this conversation about pivot power and spontaneity. You know, if you're so attached to what things are supposed to look like, you forget to apply innovation and be in the moment with people. The other characteristic that I want to put out here is either or thinking. It's either this or is that. No nuance, no gradation. And when you operate from that level of rigidity, once again, no opportunity to switch gears, to think a new thought. Thank goodness the Wright brothers didn't think either this or that and kept pushing, so now we're engaging in flight, so it's really important to be spontaneous and just to be intuitive in spaces when you're working with people and supporting them on their healing journeys and not rigid. What else did I want to? Power hoarding. So the thing about the white coat syndrome or phenomenon is we're taught that if the doctor comes in and they say it's this or that, no, you don't need the surgery. No, don't, what is it called? The cerclage. You don't need that. Then we go along with it because they have the white coat on. They know more than we know about our own bodies. And it's problematic that it's that way. And I even say for you all, especially those who are studying and, you're still getting guidance from more seasoned clinicians and providers, that is so important for you not to fall under that, indoctrination that the person who has more experience can't possibly be questioned. How are we going to innovate and grow and transform? They may be wrong. They're wrong a lot. And when I think about the concept of practicing medicine, practice is the key word, that we don't know everything. There's some things we absolutely do know and other things we do not. So I just want to invite you to do your homework, do the research. I no longer use as much bias, implicit bias, just speak about diversity. I'm speaking about white supremacy culture and racism and their impact. white supremacy culture, patriarchy, the twins, and the elixir that they drink all the time is capitalism. And we get driven by that. And then once again, lives are lost and we lose the essence of our own humanity because we're stripping away the things that make us most powerful as beings, which is our emotional intelligence, our ability to be empathetic, who we are as creative beings, all of that. So I'll close and just say how grateful I am to be in this space. And I encourage you, if you haven't watched the documentary, not because I'm in it, but watch Aftershock so it will inform your practice in the days and months and years to come. I wish you long practice, but I wish you practice in integrity. And I'm complete.
Incredible. I want to thank Ekua, and I want to thank Shawnee, and I want to thank Alexia as well for just sharing from your personal perspectives. One question that comes to mind that I think is important for us to maybe consider, I think individuals have talked about what individual birthing people can do, and what we have to understand about the culture that we find ourselves in. And I'd be curious, and I'll start with Shawnee and then go to Ekua, if you can comment as well on what infrastructural changes are needed and what institutional changes we should be pushing as community members, as clinicians, as just citizens in this world, that are needed, given your experience, within the birthing world as doulas and supports, and your experience as someone who's lost someone from, a horrible experience. What would you say that institutions need to think about in terms of infrastructural changes? Shawnee?
Yes, I think with the release of the egoic posture and the arrogance, the United States really needs to have, I'm saying this just to make a point, a come to Jesus moment. I would really say a come to midwifery moment, right? Recognizing that our other countries practice or integrate midwifery into the care of birthing people and to the care of mothers and babies. And the outcomes that they get is that people survive and thrive. And we have it right there before us, but we haven't tapped in and embraced that fully. And that's problematic. That's what works. And we won't do it, right? So that's mind-boggling for me. And then the other piece, and Ekua, you said it earlier, you talked about, I would say, integrating sexual and reproductive health learning very, very young. So we know that we have a vagina and what it looks like, and just how to navigate before we're preparing to get pregnant. That's too late, right? You need to know about this when you're in kindergarten. Like my grandbaby Anari knows her body, and my grandson will teach him. We're teaching him, and we'll continue to teach him about his body. It starts there. It's a rite of passage. And then finally, I will say, and I think I lost it. Oh my goodness! But I'm going to pass to.
We'll come back if he gets back. Okay?
I lost it. Yeah.
I touched on this before. Yes, of course, I second midwifery, but more midwives. I think we need a Become a Midwife campaign, honestly, in our community, so we can care for ourselves. But for those of us who are physicians caring for birthing moms, I once had the honor of working with a physician. Her name was Dr. Warrior Edwards, and she was trained by midwives. And her biggest thing was that, unfortunately, her peers didn't know what natural birth looked like. In the training, unfortunately, in our culture and our institutions, it's about intervening. It's about moving labor along. It's about what are we doing next if nothing happens, and that sort of thing. And she was pushing for doctors, physicians, OBs to train under midwives, so they can know what natural birth looks like, so they can stop interfering in those low risk situations that sometimes the interference alone is what, causes what we call cascade of events, in our doula world. So I think if doctors could kind of take a step back and learn from midwives and learn from, holistic approaches, that would be huge. Of course, the health education, and just really just making, I don't know how you do this with our capitalistic system, but just making sure that we are meeting every person where they are and giving them what they need, that there is no cookie cutter, protocols, if this, then that, like you can't do this if this, and like those aren't working, because every woman is different and everyone knows different things about themselves and their bodies. Their support systems are different. And we really need to, honor everyone as an individual. So I love what you said, Shawnee, about, the emotional intelligence and because I laugh about this all the time. I know whenever I'm in a room full of doctors, I always, I'm like, every time I bring up, hospital shows, like it's really preposterous, but you see it all the time. All of those things on the right side come up when it is a peer on the table. They will intubate and do CPR for 3 to 23 minutes after they called it. Like when it's one of ours, we move different. So like that whole thing where I once had a doula who came to speak at Social Medicine Month, just told the interns, they were like, don't take care of my people unless you love them. We need love in this space. And it was so powerful when Monica said that. It's just like, if you don't have any love for who is in front of you, if you don't care what happens, if you're not willing to give them the care that you want your sister, your mother, your wife, your daughter to get, like, then do something else.
Yeah. Wow, that's very powerful. Teresa has a question. Go ahead, Teresa.
Not so much a question,
Or
but
comment,
just
go for it.
that I'm a doula, and just looking at, you had the question of what can be enacted to make a difference or to change this thing. I think one of the first things to do is to really understand, as Ekua had mentioned earlier, the brutal origins of our entire medical system, right? So experimentation on enslaved human beings, tortured under captivity, right? So your medical advances, your obstetrics, all that, without anesthesia, the experimentation, the brutality of it, because it carries on throughout the thread of medicine, right? So when I enter rooms where someone wants to have a physiological birth, there's this other place of, we are here to prevent, we're here to continuously intervene, we're here to insert ourselves in this process. And I think the thing that has to be done is, one, that institution somehow has to recognize their origins and and why it keeps playing out. And then the second thing is to have people in those rooms, not only with midwives, but also with, doulas, or if the institution it does what it needs to do, then maybe it won't need doulas, right? But and the other thing too is to really spend a lot of time educating our clients, our patients, right? With just letting them know that physiological birth is possible, and that it can be the least problematic if you have a low risk sort of situation, and ways to keep, to mitigate risk, right? Because, like we keep talking about maternal mortality, and we're talking about how it impacts Black women in the United States specifically, and how you're 8 times more likely to die in New York City if you're a Black woman, regardless of your level of education. The other thing that's missing is that in general, for a so-called first world nation, the United States has the worst maternal mortality for everyone, right? Even including white women. So then there's something to be said about the system being rotten for everyone, and then even more so for the people that are here and are part of the continuation of this captivity and this brutality. So my thing is to really educate patients and to encourage people advocating for themselves, because it's hard as a doula to advocate, but I think that when people are educated and they're partnered with people that are there to support them, they can make that difference. But like, it's very simple to me, like an unnecessary intervention or unnecessary C-section could result in a number of things. So why have that be the first option when your OB is impatient, So
Mhm.
those are my, I would say that's my entire dollar, not even cent,
Thank you for sharing that. I think that you've said so many really rich things that there's kind of two themes that I think it's important for us to bring up again, which is that there isn't natural protection by these positions of privilege. And so there are people who are physicians who are dying from this, people who, are in this world as advocates, and people who are using their voices to speak up who are still dying. And I'll just go back to Aftershock. Shawnee's entire family was well-versed and supported her and spoke up. Amber Isaac Rose was on social media talking about how she was getting substandard care and was concerned and talked about it in real time, and she still passed. And so I think what is important to hear, we focused on a series of levels of interventions. We focused on kind of personal level interventions, institutional level, and then kind of systemic levels. I hope that people are listening and able to hear that there are things that we as community members can do to keep ourselves and each other safe. But these systems have to change because, as Teresa just said, no one is doing well when it comes to birthing in the richest country in the world. And that means that those of us who are historically marginalized will suffer even more because of the ways that the system is set up, and because of what Shawnee has named so richly, white supremacist culture and all of its impacts. I know that Rebecca also has a question. Go ahead, Rebecca.
Thank you so much. I really started to understand a little bit more about the maternal mortality and morbidity crisis once I stepped foot in the hospital. I'm an outpatient pelvic health therapist by background, but I created a program where not only every woman gets physical therapy after birth in hospital systems, but their doctors are being trained on the value of using us on their team. Because once that person indicates that they want a physical therapist on their team, then that order is in and we can act independently. Until that happens, we can't. And that's something that I have to educate now people before they even step foot into the hospital, to have a physical therapist on your team, because we're the only providers who just don't take vital signs when they're in bed. We look at everything from swelling in the legs to how they're able to stand in the shower. If we are demanding that women be able to go home, go up and down stairs in a multi-level apartment, walk and carry their baby, get in and out of bed that doesn't look like a hospital bed, be in that position for 3 days of recovery in a 45-degree angle across their incision, be pooling fluid in their legs, and we expect them to do that, but we don't evaluate how their heart and blood pressure will respond to activity, we're practicing unethically. And I don't say that lightly. And so a physical therapist will ensure at least that person is safe and demand that a home health therapist visits her in the home. So no, we don't have midwifery care yet being taught to elementary and high school students. No, we don't have programs that are not political that allow us to teach young girls and young boys about their bodies, but we have acute care occupational physical therapy system therapists in our systems right now that we are not using. And these professionals are doctors like myself who can ensure care and act independently once the order is in and once that person wants our services. Thank you.
That was so excellent and so well said. I think it's one of those exactly kind of institutional practices that can be put into place that would be really helpful. We have a comment here asking for clarification on what we all mean by physiologic birth. Maybe I'll turn it over to Alexia to kind of explain. It's from one of our trainees, just wanting to make sure that they're clear on what we mean by that.
Yeah, so physiologic birth would be birth as our human bodies are capable of having. So not a C-section, not a birth that is aided with Pitocin, having the water artificially broken, or the membranes artificially broken, excuse me. But those are things that are sometimes necessary, but we do them probably more often than we need to. And we do those things for often not physiological reasons. We, as was mentioned, we sort of hasten the process or attempt to hasten the process, which can lead to complications, symptoms, or which can produce findings, abnormal fetal tracings that result in C-sections that lead to complications and lead to a number of unnecessary deaths. So it's kind of the exact opposite of what we do. Like, how often do you read a chart of a newborn or of a woman who's just given birth that says it's a normal spontaneous vaginal delivery? I don't know when's the last time I've seen that, because there's so much medical intervention for something that can happen physiologically and naturally, even in the hospital setting. We just don't allow that.
Thank you. I'm going to turn it over to Shawnee and Ekua for just final comments as we come to a close. Just what do you want to leave our audience members with, apart from absolutely watch the documentary? It is a hard watch, but very, very powerful, and does fill you with hope about what is possible for the future. Ekua, I'll start with you and then turn it over to Shawnee. I'll give you guys each a minute, just so we can let people go by 6.
Yes, everything that was said, but also, yes, watch the documentary, but stay informed. I remember when this came out, it was the picture on my slide, pregnancy associated mortality, and there's one for severe maternal morbidity. And it came out, and we actually got funding to mail it to doctors, right? and because doctors didn't have this, doctors didn't know. So really, like, staying involved with the statistics. Many doctors become administrators, and they work in policy and things like that. And if you haven't looked at the severe maternal morbidity for New York City, please look at it, because Morrisania, there's 102 births. In East New York, there's 268 births, deaths, and severe morbidity, 215. In Williamsbridge is 158 compared to Chelsea, which is 31, compared to the Upper East Side, which is 68. Like, this is now. Like, this is here in our backyard. These are our patients, Fordham, Morrisania. We're seeing patients here at this institution. And when you see like double digits in one group of people and triple digits in another, like, do something, please. Do something, get involved, like, give money, give your time. Just please, just continue to pay attention and just stay abreast, because, the state, the city, the feds, like, it's indicator du jour is what I call it, and it's like, this problem has been there for a long time, and, it just needs us to really just stay on top of it and stay intentional. Thank you very much for listening.
Thank you. Shawnee?
Yes, so my final words are about you. Just once again, how I started. What's your birth story? You survived, and you have a responsibility to make sure that others make it here and are able to honor and live their purposes. You have an accountability to do your due diligence and study beyond what the books say about what the medical profession calls for and your focus in it, but also studying all of the other factors, such as white supremacy, such as the historical framework for health, and interrogate what you're being taught, because once again, the narrative has been dictated by these systems and structures that don't align with Black, Indigenous people of color and their lived experiences. So I encourage you to do that. And this weekend, if you're available, and if I haven't sufficiently triggered you so much that you never want to see me again, I'm doing a conference called the Motherwit Conference, and I invite you to come. Our theme this year is birthing with gravity. And I didn't mention this, Ekua didn't mention it either. We birth strapped down to the bed with wires and monitors and the tracings and the this and the that. And our Indigenous brothers and sisters, birthing people, birth with gravity. They kneel, they get on their knees, they do whatever they need to do, and they let the earth support them. And so we want to birth with gravity, not just literally, but figuratively, policies, and practices and the politics and the power we wield. Bring all of you to the work. We need you holistically looking at these lives and taking accountability just like you would if it was your sister, daughter, auntie, friend. We thank you. We thank you. We thank you for all that you do. And I'm complete.
Thank you so much. Thank you for everyone for joining. Thank you for those who offered comments and questions and just were in this space together. I want to again close by saying that this conversation isn't easy for many of you, many of us, but I appreciate folks being here and honoring this space with your attention and with your focus. Our next round is on November 15th. We'd always welcome your feedback. I've shared the feedback link in the chat. You can also point your camera to this link and go right to the survey. But just thank you. I'm going to take a minute and thank Ekua so much. She stepped in last minute to do this and did a tremendous job. I want to thank Shawnee for her bravery, her honesty, her challenge. There is a quote that is now my favorite quote that comes from Shawnee, which is that conflict is a choice. And combat is not conflict. And I think that that's really something that I always think about, how conflict leads us to a place where we can make improvements. And I think the comments on white supremacy for some of us may be hard to hear, and yet it's leading us towards a place of healing and fixing these systems. Thank you, thank you, thank you all for being here. We will see you November 15th.
Thank you.
Thank you.
Thank you.
Thank you. Thank you.